Welcome. I'm Dr. Jesse Morse, and I wanted to thank you for tuning in. This is episode 2 of the Regenerative Medicine podcast from the Osteopathic Center. I'm recording here on the second floor of our Miami clinic, and this is the lobby. If you're watching on YouTube, you can see how beautiful it is. We wanted to create a podcast here that kind of exemplified exactly not only what it is we do here, but how we combine a combination of traditional orthopedic approach as well as add elements of integrative medicine and traditional regenerative medicine and the new and up-and-coming options as we evaluate patients depending on what they're coming in for, and exactly provide them a full menu of options, as I like to call it, to give them an idea of exactly what their injury is, how to properly diagnose it, and exactly how to treat it, whether they want surgery or they don't want surgery. So this specific podcast, we will particularly talk about the shoulder. I will briefly introduce myself to give you an idea of exactly what my background is and how I was treating these before, and now how I've grown to treat shoulder injuries now. So traditionally, I did a sports medicine fellowship at the University of South Florida, where I was working on a lot of traditional patients as well as professional and non-professional athletes. We had all different options from traditional orthopedics as well as regenerative medicine options there. That's where I did a lot of my ultrasound training, which is fantastic for the shoulder. You can really see a lot of the ligaments, tendons, and musculature within the shoulder, specifically with an ultrasound, as long as you kind of know what you're doing. The inside of the shoulder, you really need an MRI to kind of evaluate the severity of a labrum, the quality of the labrum, and then you need x-rays, really helpful for evaluating the bone, any arthritis or any fractures. So we kind of use all of these modalities, and I've learned to use them as I graduated from fellowship and started in my attending life, so to speak. I ran an orthopedic clinic that was a combination between traditional orthopedics and walk-in, as well as a little bit of regenerative medicine. And I got the feeling for how all of these shoulder injuries were treated traditionally if you were to go into an orthopedic clinic. And since I have developed more of a broader based approach that I incorporate traditional sports medicine and traditional approach, as well as adding in regenerative medicine and some integrative medicine approaches as well. So we will try to do this for each of the main body parts. I'm going to start with the shoulder today. We'll cover other body parts like the knee and maybe the hip or the ankle over the next couple of weeks. And eventually we may even go into individual injuries and how to treat them and which approaches to take seem to be the most effective. So for shoulder injuries, you have a bunch of different options. You have traditional arthritis, which can be either glenohumeral, which is the main ball and socket joint, or you can have acriomioclavicular, AC, which is basically at the tip of your shoulder, and that's for women, that's kind of where the bra strap sits. Both of these are not super common, but they can happen, and they do happen. Glenohumeral arthritis is much more common in manual laborers, as sports players that have a tendency to throw the ball with that hand. And surgeons are known to have this, especially veteran ones that have been doing it for a long period of time, or anybody that suffered an injury. As far as acriomioclavicular, it's a combination between pain with reaching out in front and over across the shoulder, almost like you're trying to grab a seatbelt. That's usually AC joint pain, and this is usually throbbing, aching pain, and there's a couple different ways to treat it. We'll talk about that in a little bit. Rotator cuff issues are by far the most common out of any shoulder injury, and this is usually a combination of 4 different ligaments and really tendons as they insert in front and in back of the shoulder, and this usually is what most people describe as a throbbing, aching pain. It may go down the side of their arm. That's a very common description, with that being said, usually we can treat this with a combination of therapy and other options, whereas sometimes it's a little too far gone, and sometimes surgery is an option, but we'll talk about that in a little bit. The other major injury in the shoulder is a labral tear, and labral tears traditionally, they have a tendency to really bother people. They are more looseness, kind of pain with certain ranges of motion, feeling like the shoulder is not staying in the socket. Usually can happen after a fall or lifting something heavier than expected, or lifting something up and maybe it pulled it off the socket. I've done other videos describing specifically labral injuries, and I will link them in the description below. But the final one additional location of injury is to the biceps, and the biceps tendon, and that is actually in the front of the shoulder. This is usually the long head of the biceps, and traditionally people have throbbing, aching pain right in the front of the shoulder, and they think it's the shoulder, but in actuality it's the bicep tendon that inserts into the top of the shoulder. And oftentimes there will be multiple injuries, and that's where it gets a little tricky. Which one can be treated with traditional medicine, which one needs surgery, which one can be benefited with maybe a little stem cell or PRP, or depending on how aggressive you want to be. So there are three different approaches that you can take to any injury or any class of injuries traditionally in orthopedics. One is the traditional orthopedic approach that you can get at any orthopedic clinic, and if you're looking for that type of approach, then most orthopedic doctors are sufficient and very good at what they do. Sometimes they will do a cortisone injection, sometimes they will opt for physical therapy, sometimes surgery is the right answer. Then you have more of an integrative approach that can take something like ozone, which is an oxygenated, hyperoxygenated gas, very common in South America and commonly used in Europe, that can be used to inject locally, that can help some of the decrease inflammation, help with kind of decrease some of the poor oxygenation of the tissues. That's more of an integrative medicine approach. And then regenerative medicine is either taking prolotherapy, which is essentially sugar water or dextrose. You can also take PRP, which is blood taken from your arm, the plasma, and the platelet-rich layer. Or you can take stem cells, whether they're coming out of your bone marrow in your hip or your fat. Or you can even take amniotic tissue allografting, and you actually inject any of these products in and around the tendon to help regrow the tissue and fix the tissue. Depending on which product you choose will depend on how effective it is and how many times you need to do it. So these are the kind of general range of options for orthopedics, predominantly non-surgical orthopedics. But some people would rather have a traditional approach where they know they're getting cortisone and they're okay with it. And they put that in, whether it's for bursitis, whether it's for rotator cuff injury, so on and so forth. The issue with that, there is some data to support that it may be damaging the local tissues, or if you're using an anesthetic like lidocaine, there can be some concerns with damaging some of the cells because of the toxicity of that. And there also is the issue that it's essentially not fixing the tissue, but instead just decreasing the inflammation and essentially preventing the injury from coming back for a couple months or a couple weeks, and then the injury comes back again. Physical therapy is a very common option, which is very effective, traditionally helping to realign and remold the way that someone does a specific movement to try to get it back to how it should be. But if there's an injury, you may be kind of cheating and doing it a different way, which then throws off the natural body mechanics. both traditional and regenerative medicine have a tendency to use physical therapy often because of how beneficial it is. And I've had really good luck with patients who do physical therapy, specifically for rotator cuff injuries, because a rotator cuff injury is very debilitating. Even opening a door is challenging. Trying to sleep, it can be miserable. Picking up anything out in front or overhead is a nightmare, and it literally can make someone who should normally have a healthy, without concern arm pretty much be limited and be very ineffective as a result. The regenerative medicine options focus more on trying to stimulate the tissue to heal itself, or to provide certain growth factors and products to provide almost a scaffolding, like you're fixing a building, and try to fix or heal some of those tissues so that they can perform the functions that you're asking of them. A lot of people would prefer to take a non-delaying and aggressive approach, where they but at the same time they don't want to put any chemicals in their body, and they prefer more of a natural approach. And that's those people have a tendency to gravitate towards regenerative medicine because it is essentially using your body and your cells and just kind of relocating them. One of the other points that I wanted to highlight is that there are two essentially types of injuries, or stages of injuries. You have an acute injury that just happened ideally within the past 6 weeks, and then you have more of a chronic injury, whether it's 6 weeks, 7, 8 weeks old, or 6 years old. And then you kind of have that gray area where you have a chronic injury that also happens to have an acute flare. So essentially you call it acute on chronic injury, where there's some chronic damage and maybe you re-injured it, so now you have new inflammation as a result of that. The acute injuries usually are more described as a tendinitis if it's involving a tendon. So the way that the body is built, you have a muscle which essentially turns into a tendon, which attaches to a bone. The bone heals very well if it's injured. The muscle heals very well because they both have very good blood supplies. Unfortunately, the connecting piece, the tendon, does not heal very well and has a tendency to scar down or kind of fray, and when it's getting beat up, almost like a rope. The issue is same with tendons also applies to ligaments, because they have a similar purpose. They have a similar blood flow pattern, and a majority of them, unfortunately, do not heal. That's why we have a tendency to tear an ACL in the knee, because it just simply does not heal well, and it cannot withstand the pressure of a certain movement. Tendinopathy is more of a chronic issue, where the tendon is continuing to get beat up, and instead of healing, because it has poor healing properties, the tissues, which would normally be some nice, beautiful, fine woven fibers, are now all crisscrossed and mangled, and it just doesn't have the same recognizable pattern that you'd expect to see when it was brand new. A lot of the times this leads to throbbing, aching pain that can be very uncomfortable. That also usually translates to a decrease in the range of motion. And unfortunately, many, if not all of us, will have multiple forms of tendinopathy because of the wear and tear that we've used in our body parts over the years. Whether it is our rotator cuff in our shoulder, whether it is our Achilles tendon in our heel/ankle, all of these are tendons that we are using multiple, potentially hundreds of times per day, and unfortunately they just aren't able to heal to the same strength that they were when we were 10, 15, 20 years old. The acute injuries usually lead to acute tearing, and if that's not properly addressed, that's going to turn to chronic scar tissue. That's going to turn to more chronic tendinopathy, which will then lead to future injuries, because that scar tissue and that tendinopathy doesn't have the same strength or flexibility that the original tendon did. As far as regenerative medicine, it's very effective in different parts of the shoulder. Take, for instance, arthritis, whether it's glenohumeral or acriomioclavicular, it can be very effective. There's actually something called A2M, or alpha-2 macroglobulin, that is that can be very effective for arthritis in particular. PRP has mixed results with this issue with arthritis because it just doesn't seem to heal as well as some of the other options. It will help, it's just not ideal. When we're talking about rotator cuff injuries, unfortunately, they are notorious. Even a healthy 22-year-old who tears one of their rotator cuff tendons, depending on the severity of the tear, they will significantly lead to some issues in the future. And if they don't properly address it, they're going to have not only scar tissue, but probably pain and weakness and decreased strength in that tendon. So there are four main rotator cuff tendons. You have the infraspinatus, the supraspinatus, the subscapularis, and the teres minor. The supraspinatus and the subscapularis are the two main tendons that are on the front of the shoulder and the top of the shoulder. Whereas the infraspinatus and the teres minor, they're more so on the back of the shoulder. The ones on the front or top of the shoulder are the what I call the big boys. They pretty much do the majority of the heavy lifting. Anything out in front or across your body, use one or both of those tendons. Whereas infraspinatus is more of a helper, a very large muscle, but doesn't really seem to help. It doesn't really seem to help with a lot of our motions. And then the teres minor is very similar. It's a larger muscle, but it doesn't serve as many roles. You can injure any and all of these. Unfortunately, whether it's from chronic wear or tear, whether it's from a fall, whether it is from something that it was a little bit beat up and then maybe you fell, or you picked up something that you thought was lighter than it was, or maybe you tried to catch something that was falling and it ended up tearing a little bit more. These are very frustrating injuries within the rotator cuff because essentially whenever you stretch your elbow out and reach out in front of you, you have to use the rotator cuff. That's all we have. When we have our hands close to our body, we can use back, we can use core, but once those hand and elbow is extended, you essentially have to use the rotator cuff muscles. So if one or two or three of them are really injured, you're going to be feeling it, and you're going to try to do what you can to try to cheat to prevent from having pain and potentially injuring it more. The rotator cuff has a tendency to respond more so to regenerative medicine and along with physical therapy. If you want a traditional approach, here's what we would traditionally offer you: a cortisone injection, physical therapy, and then if either of those two working and they don't want to go the regenerative medicine route, you would offer either a rotator cuff repair or a shoulder replacement, depending on the severity of the damage. If the issue with rotator cuff repair is that you're going to be in a sling for 6 weeks, and then the following 6 weeks you will gradually ramp up to about 5 pounds of weight. So essentially you're almost immobilized for over 3 months or close to 3 months at some limited capacity, and then you gradually have to work your way back up. Why is this the way it is? Because essentially you are tying a tendon with essentially a big piece of rope and then tacking it back into the bone using a big deep screw. Well, if you start lifting heavy, any type of heavy weight, before that screw is implanted and secure, you're going to rip that bone out of you're going to rip that screw out of that bone, and you're going to start from scratch. So that's why rotator cuff repairs take so long to heal. They work. It's just a long journey, and unfortunately, as the older we get, the more poorly we heal, and the longer it takes to heal. A traditional rotator cuff repair can take anywhere from 6 months to 9 months, depending on the severity of the damage and the age level and what you're trying to get back to. Are you just trying to reach out overhead to grab something out of the cabinet, or are you a professional athlete that is actually trying to catch a ball or throw a ball at elevated velocity. So just a lot of it depends on your goals and what you're trying to personally do. As far as regenerative medicine, when it comes to rotator cuff, usually depending on the severity, you can start with prolotherapy. It's usually not going to be strong enough or require a ton of treatments, 5 to 10 different rounds of injections. If you want to bounce up to the next level, talking about PRP can be very effective, but you may need a couple of rounds of PRP depending on the severity of the damage and also depending on the quality of the PRP you're using. Stem cell will be much better, which is about at least 3 times more potent than PRP, if not more. You may only need 1 round of PRP in addition to bone marrow. Some people will do bone marrow and then they'll follow it up with PRP a month or 6 weeks later. Everyone has their own little protocol. The most effective is probably going to be amniotic tissue allografting, which is the tissues taken from a placenta after a baby was delivered, and those tissues are flash frozen. You can use those tissues almost as a graft agent to put them directly into the tissue that's damaged. These work very well, very quickly. They don't create as much pain after the injection, and they have a tendency to work very quickly and actually create a beautiful new strong tissue. They may not ever be perfect or as strong as they were when you were 20, but they will be much better than before the injection. Physical therapy is definitely needed afterwards, regardless of what option you choose, and sometimes it's enough by itself. Let's talk a little bit about labral tears before we close this up. So the labrum is essentially the cartilage that holds the ball within the socket. So if you were to look at your shoulder and take out the shoulder and kind of look at it from the side, as if someone was standing next to you and they just turned over and looked straight at your shoulder, you would see a labrum almost looked like a clock. Now, depending on the severity of the tear, you can have, say, a labral tear that's only between 12 and 1 o'clock, which would be a small tear, or you can have one that's between 12 and 6 o'clock, which would be a very large tear. And they usually describe the tear depending on how large it is and where it's located. Is it in the front? Is it in the back? Is it on the top? Is it on the bottom? The larger the tear, the more unstable that shoulder is going to be, and the more pain they're going to be in and feel like that shoulder is loose. Anybody who's dislocated their shoulder, by definition, pretty much has to have some labral tearing. You may have heard of the term slap tear, S-L-A-P, and that basically describes the location of the tear, more so on the top part than on the bottom. In terms of treatment options, we're usually thinking of a traditional approach. You can do physical therapy. It's usually not going to be strong enough, and you probably will need surgery. A labral repair is very challenging. There's sutures that are in place to kind of help the tissue, but unfortunately some people are prone to re-tearing it because of the poor blood supply after the fact. That usually takes a good 3 to 6 months, sometimes longer, depending on the severity of the tear and the additional damage involved. Regenerative medicine is a very effective option for labral tears. The problem is it requires some of the stronger regenerative medicine options. The prolotherapies and the PRPs just don't seem to have enough tissues. They don't seem to have enough growth factors and stem cells in there to really make a difference. You may have to go 3, 4, 5 times with PRP to ever really see a difference in a large labral tear. Whereas if you do a bone marrow or an amniotic tissue allograft, you're probably going to get significantly more effectiveness in only 1 or 2 injections. Remember, you're not going in there and surgically correcting the tissues, but you are planting the best tissues that you can get, whether it's from yourself or from someone else, into the area and telling the body, hey, fix this and go to work. As far as The last option, which is biceps. So you have a couple different injuries. When we think of biceps, most people think of the middle of the bicep or towards the elbow, but in actuality, the bicep goes all the way from the middle of the arm all the way into the shoulder. There are two bicep tendons, one that is very thick and strong that inserts into the chest wall, and we usually don't ever worry about that one. Whereas the long head of the bicep is the one that inserts into the top of the labrum in the shoulder, and this is usually the one that gives us the biggest trouble. This is a very uncomfortable, throbbing, aching pain. The tendon actually sits in a groove, and sometimes when that groove gets filled up with fluid, the tendon can actually pop in and out of the groove, which can be very, very painful. Acutely, you can inject steroid into and around underneath the tendon. You don't want to inject it into the tendon because you can rupture it. That will help temporarily, but you're really not fixing anything. You're just essentially calming down the inflammation. Surgically, you have a couple different options. You can attempt to repair the actual shoulder and where the bicep inserts. Unfortunately, those results have not been as good as if you were to just cut the bicep tendon and tack it onto the bone in what we call a tenodesis. That is especially effective because the tendon is no longer pulling at the labrum and causing pain. It's no longer causing inflammation. And it only accounts for about 15% of our strength of our bicep. So you don't really lose much strength, but you also, if you were to tear that bicep tendon, you don't get that classic Popeye deformity where you have this bulging of the bicep where the actual tendon, instead of being attached, has fallen and torn down and is now kind of peaked in the middle of your arm. As far as regenerative medicine options, you can put a bunch of different products in there depending on the severity of the tear. Usually you can get these to calm down along with a little or a lot of physical therapy depending on the severity of the injury. So as you can tell, if you're looking for regenerative medicine options, you want to find a specialist that knows what they're talking about, that has done the training, that has done the procedures, that uses ultrasound guidance to see things in real time and can move the probe around and actually say, all right, when I'm moving the probe this way, what does the tendon do? When I move the probe this way, what does that tendon do? MRIs are fantastic, but unfortunately they are static. Meaning if you move during an MRI, there's a big blurry image, and you can't use that when you're in the middle of an injection. So you have to use something that's dynamic, whether it's a CAT scan or an ultrasound. And when you do your injections, these are the things that make the injection much more accurate and the results much better. So this will conclude our second episode, predominantly describing the different treatment options of the shoulder. If you like the video, hit the thumbs up and hit the subscribe, whether you're listening on podcast or watching on YouTube, and check out some of the other videos and podcast episodes. Thank you very much for tuning in. Take care.